Imagine a patient walks into a clinic with a tiny, really painful blister on the very tip of their nose.
Right, which sounds incredibly minor.
Exactly. To most people, and honestly even to some medical professionals, it just looks like a simple skin irritation, like maybe a blocked pore or a cold sore.
Yeah, totally harmless.
But to a neurologist, that tiny blister is an absolute red flashing emergency because it is a highly specific siren warning that this patient is, well, about to lose their vision.
Yeah, it's known as the Hutchinson sign. And it's fascinating because the tip of your nose is innervated by the nasociliary branch of the trigeminal nerve.
Okay, that's a mouthful.
It is, but basically that specific nerve branch shares the exact same wiring as your eye.
Oh.
Right. So when a latent virus erupts at the end of that nasal branch, there is like an 80% probability that it's simultaneously attacking the ocular structures.
Wait, 80%? That's massive.
It is. We are talking about a microscopic invader threatening to cause permanent blindness if it's not shit with antivirals immediately.
Which completely shatters how we normally think about getting sick. I mean, usually you catch a bug, you get a fever, your immune system clears it out, and the battlefield goes quiet.
Exactly. The threat is eliminated.
But when you look at the nervous system, that predictable battlefield turns into like an espionage thriller. The invaders don't just attack, they establish safe houses in your spinal column.
They do.
They hijack the communication cables, and they actively evade the body's security systems for literally decades.
It is the absolute definition of neurological sabotage. And what makes it so challenging for clinicians is that the resulting nerve damage, the numbness, the pain, the sudden paralysis,
Right.
It can effortlessly mimic degenerative diseases or autoimmune disorders or even genetic conditions.
Unmasking those saboteurs is our mission for this deep dive. We are exploring the surprisingly vast, structurally complex world of infectious neuropathies.
It's a huge topic.
It really is.
Yeah.
And our map for this comes from incredibly detailed medical review published in the October 2023 issue of Continuum, Lifelong Learning in Neurology. It specifically focuses on the rigorous clinical research of Dr. Amy K. Bogle and Dr. Pushpa Narayanaswamy.
Incredible researchers.
Absolutely. And if you or someone you know has ever dealt with mysterious nerve pain or sudden limb weakness, this research is vital to understand. Because the ultimate aha moment here is reversibility.
Yes, that is the key takeaway. I mean, many genetic or neurodegenerative diseases, they can only be managed or maybe slowed down.
You can't cure them.
Right. But infectious neuropathies often present a curative window. If a physician knows exactly which viral footprint or bacterial signature to look for, they can treat the underlying infection.
Stop the crossfire entirely.
Exactly. Stop the crossfire and actually allow the nervous system to heal.
Okay, let's unpack the mechanics of that crossfire. Because a pathogen, like a virus or a bacterium, it doesn't just magically make a nerve stop working.
No, it has to alter the biology somehow.
Right. And from reading the review, it seems like these pathogens operate on two main strategies. They either breach the nerve cells directly, or they trick the immune system into doing the dirty work for them.
Yeah, those are the two definitive mechanisms. So in direct invasion, the pathogen physically enters the axon or the surrounding support cells. It utilizes the nerve's own metabolic machinery to replicate and eventually destroys the cell from the inside out.
Brutal. And the indirect one.
In the indirect mechanism, the pathogen triggers such an aggressive, chaotic immune response that your own white blood cells actually become confused.
Like friendly fire.
Precisely. They mistake the proteins on the surface of your nerves for the pathogen, and they start stripping away the myelin, which is the protective coating of the nerve.
We see that stealth strategy really perfected by the viruses. I mean, they are the ultimate sleeper agents. The review highlights herpes viruses specifically, like we all know varicella zoster virus or VZV causes chickenpox.
Sure, almost everyone knows that.
But what's fascinating is its escape route. It doesn't actually get cleared from the body after you recover.
Not at all. It retreats retrogradely up the sensory nerves to establish latency.
It's a biological time bomb.
It really is. VZV travels back up the sensory fibers and embeds itself in the dorsal root ganglia alongside the spinal cord or the trigeminal ganglia up in the skull.
And it just hides there.
Yeah, it splices its DNA right into the host cells and goes completely dormant. It actually stops producing the proteins that would normally flag it for destruction by the immune system's T cells.
So it's just sitting there in the dark, basically monitoring the body's security cameras. And the detonator is immunosuppression.
Exactly.
If you age, or if you require immunosuppressant drugs for another condition, your surveillance network drops. VZV senses that gap, wakes up, travels back down that specific sensory nerve, and erupts on the skin as shingles.
Which brings us right back to the Hutchinson sign. That localized eruption on the nose isn't random. It maps perfectly to the territory of the specific nerve the virus was hiding out in.
Wow, that makes so much sense.
And VZV isn't the only herpes virus employing this tactic. Cytomegalovirus, or CMV, operates with similar patients, but its target is entirely different.
How so?
Well, for immunocompetent individuals, CMV is often completely asymptomatic. But for severely immunocompromised patients, particularly those with advanced HIV, CMV reactivates from latent monocytes and aggressively hunts the lumbosacral nerve roots.
The cauda equina, right? The horse's tail of nerves at the very base of the spine.
That's the one.
But if CMV causes sudden bilateral leg weakness, urinary retention, and severe lower back pain, that sounds exactly like a slip disc or a tumor compressing the spine.
It looks identical clinically.
So a doctor can't just guess when a patient's legs are giving out. I imagine they have to look for a specific viral footprint in the spinal fluid to prove it's an active infection.
They absolutely do. A clinician will perform a lumbar puncture to analyze the cerebrospinal fluid. If it's CMV radiculitis causing the paralysis, they are looking for a highly distinct marker, a neutrophilic pleocytosis.
Okay, I want to highlight why that's so crucial. Because neutrophils are a type of white blood cell that typically flood in to fight bacterial infections, right?
Exactly. They are the antibacterial foot soldiers.
So seeing a massive influx of neutrophils in the spinal fluid when you're dealing with a viral infection like CMV, that's a massive biological anomaly.
It's a huge paradox. It's the ultimate red flag for this specific pathology. It confirms the aggressive, destructive nature of the CMV reactivation in that space.
And once they spot that,
recognizing that anomaly allows the medical team to immediately initiate targeted antiviral therapies, which can literally halt the progression of the paralysis.
Which brings us to, honestly, the ultimate clinical puzzle in the review, HIV itself. HIV is notorious for causing a length-dependent sensory neuropathy.
It is.
But the researchers highlight a brilliant paradox here. The antiretroviral drugs used to save the patient's life, specifically the nucleoside reverse transcriptase inhibitors, or NRTIs.
Right, the standard treatment.
Yeah, they also cause a toxic neuropathy that looks incredibly similar to the viral damage.
It's incredibly frustrating for clinicians. Distinguishing between the disease and the cure requires the doctor to deeply understand the pharmacology of the toxicity.
So what's actually happening there?
Well, NRTIs are designed to inhibit the virus's ability to replicate its DNA. However, they have an off-target effect. They also inhibit human DNA polymerase gamma, which is the enzyme our cells use to replicate mitochondrial DNA.
Okay, let's connect that back to the nerves. Mitochondria are the powerhouses of the cell. The longest nerves in the body, the ones stretching all the way from the lower spine down to the tips of the toes, they have massive energy demands just to maintain their structural integrity.
Right. So when the NRTIs interfere with mitochondrial replication, those long axons literally run out of energy. They starve.
Oh, wow.
And because the energy deficit is most profound at the furthest reaches of the cell, the nerve begins dying back from the toes upward. That is why the toxic neuropathy mimics the length-dependent damage caused by the virus itself.
So if you're a physician looking at a patient with burning pain in their feet, how do you know? Like if you increase their HIV medication to fight the virus or stop the medication because it's causing the toxicity.
The review points directly to the timeline. That's your first diagnostic pillar. Toxic neuropathy almost always presents within 6 months of starting the NRTIs.
Okay, so it's a relatively fast onset.
Yeah. The second pillar is the geographical progression of the symptoms. While both are length dependent, the viral-induced HIV neuropathy is an incredibly slow burn. It takes a very long time for the nerve damage to progress from the feet up to the hands.
But with the drugs.
With NRTI toxic neuropathy, the mitochondrial starvation is so severe that we consistently see an earlier involvement of the upper extremities.
So the patient's hands start hurting months or years sooner than the viral biology would dictate.
Exactly.
That shifting geography tells the doctor the mechanism is toxic, not viral. It's just an incredible piece of clinical deduction.
It really highlights the importance of patient history.
Definitely. Now, we've seen how latent viruses use stealth, and systemic viruses cause that length-dependent damage. But the research also pivots to the emergent respiratory viruses.
Right, the modern era.
Yeah, the COVID-19 pandemic gave us a real-time global masterclass in how novel pathogens interact with the nervous system.
It did. The initial wave of the SARS-CoV-2 virus revealed a distinct neurotropism. like a biological preference for attacking nervous tissue.
Which people didn't realize at first.
No. The most ubiquitous early symptom, the sudden loss of smell and taste, it was often dismissed by the public as severe sinus congestion.
But the neurology tells a completely different story. Anosmia and ageusia are acute cranial neuropathies. The virus was physically disrupting the olfactory sensory neurons right there in the nasal epithelium.
Exactly. It wasn't congestion blocking the odor molecules, it was the communication cable to the brain being temporarily severed.
A localized, direct hit. Here's where it gets really interesting, though. The more complex neurological casualties emerged in the intensive care units.
Yeah, that was a huge challenge.
We saw a surge in severe COVID-19 patients developing mononeuropathies. Isolated, catastrophic damage to single nerves, like the ulnar nerve in the arm or the sciatic nerve in the leg.
And I'm looking at these severe ICU cases, and the fascinating distinction here is that it wasn't the virus directly eating the ulnar nerve.
Right.
The nerve casualty was actually the result of the mechanical realities of the treatment strategy colliding with the metabolic vulnerabilities of the patient.
You were referring to the biomechanics of prone positioning.
Yes.
To improve oxygenation in failing lungs, critical care teams had to place patients on their stomachs for up to 16 hours a day.
So the heavy unconscious body is resting directly on specific anatomical pinch points. The ulnar nerve at the elbow is physically crushed against the mattress.
But the review emphasizes that healthy nerves can usually tolerate some compression, right?
They can. The massive risk multipliers here were underlying metabolic conditions, like diabetes, combined with the systemic hypoxia from the failing lungs.
So it creates a double crush syndrome.
Exactly. A diabetic nerve is already microvascularly compromised. It is starved of proper blood flow and oxygen even before the patient gets to the ICU.
So you take that metabolically fragile nerve?
You subject it to the systemic oxygen deprivation of severe COVID, and then apply sustained mechanical compression. The nerve simply lacks the resilience to survive the physical pressure, resulting in an acute mononeuropathy.
So the virus creates the battlefield, putting them in the bed, but the treatment strategy accidentally causes the nerve casualty.
Well, the metabolic environment dictates the damage, but yes, the mechanical pressure is the trigger. It is a brilliant synthesis of the clinical picture by the researchers.
It really is. But we also have to look at viruses that don't need a mechanical assist, the ones that specifically haunt our motor function. We tend to associate polio with this, but the sources point out that the viral strategy of attacking motor neurons is very much active today.
Oh, absolutely. We are actively tracking a class of neurotropic viruses that specifically target the anterior horn cells in the spinal cord.
Like what?
These include West Nile virus and enterovirus D68, which is actually responsible for outbreaks of acute flaccid myelitis in children.
The anterior horn cells are essentially the motor command centers, right? They are the neurons originating in the spine that send the physical move signal out to your muscles.
That's right.
If a virus infiltrates the spinal fluid and selectively destroys those specific command centers, you don't get a symmetrical numbness in the feet. You get acute asymmetric flaccid weakness.
Yeah, a single arm or a single leg will suddenly go limp, completely losing muscle tone, and it's often accompanied by severe, painful muscle spasms.
Like they can still feel things.
Yes, the sensory nerves are entirely intact. The patient can feel everything, but the motor cable has been violently disconnected at the source. It is a stark reminder that viral tropism for the motor system remains a critical public health threat.
We've spent a lot of time on how viruses use stealth, latency, and highly specific cellular targeting. But the review also forces us to confront the bacterial threats, and the transition here is massive.
It's a totally different ballgame.
Bacteria don't bother with integrating into our DNA. They operate like a physical invading army, causing intense localized inflammation and fundamentally changing the structural architecture of the nerve.
The pathophysiology is remarkably different. Bacteria are often vector-borne or environmental. When they breach the body, they trigger robust, highly destructive inflammatory cascades that literally physically engulf the peripheral nerves.
Let's start with a threat hiding in the woods. Lyme disease, caused by the Spearsia Borrelia burgdorferi, transmitted by tick bites.
Right.
Lyme is notorious for being a great imitator, but in its early disseminated phase, when the bacteria are actively floating through the bloodstream, it has a profound affinity for the cranial nerves.
The clinical presentation is often a sudden facial palsy. And unlike a stroke, which typically affects the lower half of one side of the face, Lyme can present as bilateral facial palsy, paralyzing both sides of the face simultaneously.
Which is an incredibly rare presentation that should immediately make a clinician suspect a spirochete infection.
Immediately.
The review also details a European manifestation of Lyme called Banworth syndrome, which perfectly illustrates this bacterial inflammatory cascade.
Yeah, Banworth syndrome combines facial palsy with a profoundly painful radiculitis. That's sharp shooting nerve pain emanating right from the spinal nerve roots.
Sounds agonizing.
It is. And if you perform a lumbar puncture on these patients, the cerebrospinal fluid reveals a massive buildup of inflammatory mononuclear cells. The bacteria are essentially bathing the spinal roots in an inflammatory soup.
And here's the massive clinical trap that the review warns about. If you have that tick bite, you develop the facial palsy, and you rush to the clinic for a Lyme disease blood test, it might come back completely negative.
Right, which is so confusing for patients.
A doctor might look at that and say, well, the lab says it's not Lyme, so we'll look elsewhere.
That false negative occurs because of the biological lag in antibody production.
How so?
The standard serologic tests for Lyme disease don't look for the bacteria itself. They look for the IgM and IgG antibodies your immune system produces to fight it. And it takes weeks for the body to mount a detectable antibody response.
So the clinical imperative here is that if the early testing is negative, but the symptoms, the bilateral palsy, the painful radiculitis, if they are screaming Lyme disease, the physician cannot dismiss it.
No, they must treat empirically or retest a month later. Missing that window allows the bacteria to burrow deeper, progressing into late Lyme disease, which causes permanent exonal damage.
It really emphasizes that clinical observation and understanding the timeline of the immune response must override a single early laboratory test.
Exactly. You have to treat the patient, not just the lab result.
While Lyme bacteria operate by floating through the bloodstream and causing widespread inflammation, our next bacterial threat uses a completely different strategy. It acts more like a squatter that takes over the very architecture of the nerve.
Yeah, this is fascinating.
We need to talk about leprosy, or Hansen disease, caused by Mycobacterium leprae. We usually think of leprosy as this ancient disease confined to tropical regions, but the review explicitly flags that endemic, newly acquired cases are appearing right now in Central Florida.
The geographic footprint is shifting, and the way M. leprae damages the nervous system is completely unique among pathogens.
What does it do?
It is an obligate intracellular bacterium with a specific tropism for Schwann cells. Those are the cells that wrap around the peripheral nerves to provide insulation and metabolic support.
So it targets the insulation directly.
Right. The physical examination findings are astonishing. Because the bacteria are slowly destroying the insulation, patients develop profound patchy anesthesia. They lose all sensation in specific areas of skin, and they actually lose the autonomic ability to sweat in those patches.
Oh.
Because they cannot feel pain, they sustain repetitive microtraumas, leading to the painless skin ulcers that historically characterize the disease.
But the diagnostic hallmark, however, is palpable.
Right, it is. Because the bacteria colonize the Schwann cells, the immune system engages in a prolonged, violent fight right there inside the nerve canal. This leads to the formation of granulomas.
So the nerve gets swollen.
The nerve itself becomes engorged, structurally deformed, and physically thickened. A neurologist can literally feel the ulnar nerve at the elbow, and it will feel like a tender, beaded cord right under the skin.
I want to break down the immune response here because the sources describe two totally different clinical outcomes for leprosy. Some people get a few localized nerve issues, and others suffer massive whole body destruction.
And the bacteria is exactly the same in both scenarios. The divergent outcome is dictated entirely by the host's immune response strategy.
Let's use an analogy of two different generals fighting the exact same invading army. The first general is highly strategic. He uses cell-mediated immunity.
Okay, I like this.
He sends in macrophage foot soldiers for close quarters combat. They identify the infected Schwann cells, surround them, and basically wall them off into these dense fortresses called granulomas.
Right, and that represents the possibacillary tuberculoid presentation. The infection is trapped. The localized crossfire destroys that specific nerve, causing asymmetric damage, but the systemic spread is halted.
But the second general completely misreads the battlefield. He relies on a humoral response, shooting antibody arrows from a distance.
Which doesn't work.
Right. Because the M. leprae bacteria are hiding securely inside the Schwann cell walls. The antibodies just bounce off the cell membrane. Because the weapons are useless, the The bacteria multiply unchecked inside the cells until they burst, spreading everywhere.
which results in the multibacillary lepromatous presentation. The infection becomes widespread and symmetric. The tender, beaded thickening of the nerves happens all over the body.
So the patient's own biological miscalculation allows the bacteria to cause catastrophic systemic damage.
It is a stunning example of how our own immune system dictates the course of our neurology.
We've covered a staggering amount of cellular biology today, from viruses embedding their DNA in our spinal roots for decades, to the mechanical crush injuries of the ICU, to bacteria restructuring the ulnar nerve into a beaded cord.
It's a lot, but the unifying clinical takeaway is the power of specific observation. The peripheral nervous system is the body's ultimate alarm network, and infectious neuropathies ring hyperspecific alarms.
Like a blister on the nose.
Exactly, bilateral facial weakness, earlier upper extremity pain on an HIV drug.
These aren't random disconnected misfires. They are the highly specific fingerprints of microscopic invaders. Recognizing those fingerprints allows clinicians to deploy targeted antivirals, antibiotics, or immunotherapies.
We can neutralize the saboteurs and actually restore the communication cables.
But the parameters of this battlefield are actively expanding, and this is the vital concept from the research that we need to leave you with.
It's crucial.
We traditionally lock these infectious neuropathies to specific geographic maps. We associate Lyme disease with the forests of the Northeast United States and leprosy with the tropics or specific global pockets.
But those borders are dissolving. Climate change is actively driving a massive geographic dispersion of the vectors that carry these diseases.
So things are moving.
Rapidly. The warming environments are allowing tick populations harboring Borrelia to thrive in previously inhospitable latitudes. The environmental pockets supporting Mycobacterium leprae are shifting and expanding into new southern territories.
The clinical map of where these infectious neuropathies occur is being actively rewritten. Medical professionals and you as a patient can no longer rely on traditional geographic safety zones to rule out these stealthy pathogens.
The espionage thriller is moving to a theater near you, and the invaders are looking for new cables to cross.
Next time you take a walk in the woods or notice a strange tingling in your hands, remember the complex microscopic warfare happening just beneath the skin. Stay curious, stay vigilant, and we'll see you on the next deep dive.